So today we'll talk about the options for surgical management of peripheral vascular disease or blockages in the leg circulation. Let's kind of recap everything from the beginning. Peripheral vascular disease, again, blockages in the blood flow to the lower extremities, the 6 major risk factors: age, cigarette smoking, high blood pressure, high blood sugar, cholesterol, family history, circulation problems. Family history and age you're stuck with. You can't do anything about those, obviously. But blood pressure, cholesterol, blood sugar control is really important. Not smoking is really the key to this whole business. But really, to emphasize this again, patients who do not have symptoms from peripheral vascular disease, asymptomatic patients, no leg pain when you walk. Remember the hallmarks of peripheral vascular disease or claudication. I walk a block or two, I get tightness in my calf muscle. I stop walking, it goes away. If I walk the same distance, I get the same thing, very repetitive. If I walk up a hill, it happens quicker. If I walk fast, it happens quicker. If I carry something heavy, it's going to happen quicker. That's peripheral vascular disease claudication, intermittent claudication. If you don't have symptoms, you do not, repeat, not need intervention. There's people who are doing interventions based on the very presence of peripheral vascular disease, which is completely against all societal guidelines. So please do not get convinced to do something just because you've got some element of peripheral vascular disease. Asymptomatic patients. Now, claudication patient, claudication is that tightness in your calf muscle when you walk distances. The question is, how much is it bothering you? How much is it affecting the quality of your life? I'm 80 years old, let's say, and I can walk a block before I get onset of tightness in my calf muscle. Okay, how much is it affecting the quality of my life? Well, not much. I'm able to stop, let it recover, then go back at it again. I'm enjoying the quality of my life. It's really not hindering me in terms of what I want to do. I don't have any signs and symptoms of critical limb ischemia, which remember is a progression in that disease state. If my symptoms do not affect the quality of my life and my normal activities, again, there's absolutely no reason for surgical intervention. Absolutely not. There's people doing procedures on patients with stable claudication. Remember that story I told you about the other specialist who recommended my patient who had seen forever have intervention for stable claudication? Absolutely incorrect way of handling it. Should never happen, but unfortunately it does happen. And so those situations, you need to be aware, do not go through a procedure. Why? Because, again, the long-term implications of that procedure may be that you come back for more and more. And so if your symptoms are not that bad and your quality of life is good, it doesn't affect the quality of your life, your activities of daily living, do not get it fixed. So that's intermittent claudication. And then critical limb ischemia, totally separate. Critical limb ischemia needs intervention, generally speaking, because those patients are at risk for losing a limb. Critical limb ischemia is what's called rest pain of the toes, pain in your toes, particularly at nighttime, toes turning funny colors, dependent rubor, you lower your leg down, the toes turn kind of a bright pink red color. And in fact, that helps your symptoms. The rest pain feels better when you lower your leg down. So rest pain, particularly at nighttime, very repetitive. Wounds on the feet, sores. The sores tend to be in the heels, on the forefoot, on the toes from arterial disease, whereas vein problems, the sores tend to be around the ankles. So sores on the feet, toes, heel, and then wounds that don't heal with good wound care. And then frank gangrene of the toes, turning completely black and dead. So those are the situations where when you have critical limb ischemia, that needs some kind of intervention done to salvage the limb. Why? Because when you develop these kind of symptoms, you get the gangrene or you get the non-healing wounds that don't respond to good wound care, the risk for losing a limb is a lot higher. And then if you look at people who lose limbs, their mortality is a lot higher, meaning their 1 to 2 year chance of survival is lower. I think it's about 20% mortality over a year or two after an amputation of the limb. So critical limb ischemia needs intervention. What are the options for intervention? Well, Angiography and angiogram is really the first step. You can do CT angiograms to delineate the anatomy better, and it does save you something. But generally speaking, you need some kind of diagnostic imaging, not not ankle break, limb disease, and toe pressures, which we'll talk about in arterial duplex. Although that does help in delineating things if you're not sure. But angiography intervention or CT angiogram to delineate the anatomy. So think of this stuff again like plumbing. The plumbing's plugged up. Where is it plugged up? What can we do to fix it? Okay. So where is it plugged up? CT angiogram or conventional angiogram will tell you. CT angiogram is where you go to that big old circular machine and you get X-ray dye and it takes a look at it takes a picture from here all the way down to your toes and says, okay, here's the site of the blockage, this is what you can do about it. So it's a planning tool. Whereas conventional angiogram, you get a picture, you get a roadmap of what's going on, and then you can intervene at the same time if need be. Okay, so conventional angiogram, the way it's done is you go to the X-ray suite, you get sedated because it's a little uncomfortable, the numbing part and whatever, and sometimes the interventions can be a little uncomfortable, so a little sedation IV, numbing up the groin. So generally speaking, for example, if your left side is the problem, you usually go in through the right leg or the right arm sometimes, or the arms. That's something that we can talk about at a later date. But essentially you need access into the circulation, into the arterial circulation, the plumbing that brings blood flow down to your legs. So if your left leg is the problem, we generally speaking go through the left leg is the problem, generally speaking go through the right groin, sedation, numbing up. Why the right groin? Because anatomically it's just easier to do it that way. It's harder to go straight down the left groin because you don't get a good picture above the left groin area there. And so going through the right side, you can take a picture of the entire thing from here down and say, okay, look, here's the problem here. And then, if the top part is not a problem, you can cross over. Remember, this whole system is linked together. You can cross over from the right to the left, go down, take isolated pictures of the left side, see where the problem and see what you can do to fix it. Now, if it's amenable to minimally invasive techniques, the angioplasty, atherectomy, stenting, whatever can be done for intervention-wise to improve the circulation, usually done at the same time. There's certain nuances to this stuff, which I really don't think is the purview of what we should talk about in terms of when is it best to do a bypass versus an angioplasty. And that's kind of being delineated better currently. But I think it's safe to say that if it's something simple that can be fixed with balloon work, like a short segment blockage in the femoral artery. The femoral artery is usually the site where most of these problems are. So a femoral artery blockage, if you can cross it, open it up to reestablish the blood flow down to the foot, that always helps with the wound healing potential. Now, if you've got critical limb ischemia with wounds on the foot, you usually have femoral artery disease and artery disease below your knee too. 90% of people do. And so sometimes you'll need both areas treated, not always. Again, you're not shooting for perfection with this stuff. You're shooting to make a significant difference so that the circulation is adequate, the blood flow is adequate for wound healing. Why? What's the deal with the blood flow? Okay, well, there's really three situations, and again, this is a generalization, three situations wounds don't heal, okay? One is poor blood flow to the area. That's the arterial blood flow, the oxidative blood that comes down there. So one is poor blood flow, that's why a wound doesn't heal. So we have to reestablish the blood flow in that situation. Number two is repetitive pressure on a spot. So diabetics, if they have neuropathy and loss of sensation, they tend to put repetitive pressure on one spot. So if you put repetitive pressure on one spot, the tissue doesn't like it and it can form sores. And so if you have a sore and you put repetitive pressure on it, then it tends to not heal. The heel particularly of the foot is prone to this stuff. So non-weight bearing on the heel is really important if you have a non-healing wound. So poor blood flow, repetitive pressure at one spot, or occult or untreated infection underlying the wound, like a bone infection, osteomyelitis or something. That's the third reason wounds don't heal very well or come back really quickly. But generally speaking, if we're dealing with arterial issues, you want to improve the circulation. Again, you're not shooting for perfection, you're shooting to make it better so that the patient can heal up wounds. So you do the angiogram. If there's something that can be intervened, like a stent or angioplasty or atherectomy meaning kind of scraping out the blockage in there, plus or minus angioplasty or plus or minus stenting, improve the circulation down to the foot. Perfect. Close the artery. Now, I'll talk about closure devices at a later time. We use a little device to close that hole in the artery on the right leg, monitor people for a couple hours, let them go home, take it easy for a day or two, and then kind of go back to normal as long as you don't have any problems. Go back to normal, go back to wound care. Really important to have wound care, non-weight bearing on the surface. So that's angiography and intervention. So for example, if your blockage is too long, like you're blocked from the groin crease all the way to past the knee, and so those kind of arenas are not really amenable to endovascular or minimally invasive techniques. Now, I will say that there's pedal access, sticking the foot and going upstream and all that stuff. I think that, again, that's probably not in the purview of this discussion. Let's say you need a surgical bypass. Your cardiologist or your interventionalist, cardiovascular surgeon, whoever, determines you need a surgical bypass. What's the point of that? Okay, what's the deal with that? Well, the surgical bypass is, again, think of this like plumbing. You need to connect a good area to a good area. What do I mean? So if you're blocked from your groin crease to just above your knee, and you need that surgical bypass, then you need to connect from the groin crease area where it's open to right below where it reopens. And it reopens via collateral channels or alternative channels to get blood flow down there. So essentially you're connecting the 2 points and bypassing the blockage. That's the bypass. The material, the conduit, the material that we use really depends on the quality of your own material. We like to use your own vein. Remember, veins take blood flow back up. So the saphenous vein is what we'll try and use. That's the minor system. The deep vein systems, again, in your deep vein, that's deeper and that does most of the work. The saphenous vein we can safely use. That's what they use for heart bypasses when they take your leg vein out. So we'll sometimes use those veins to do a bypass and essentially reroute things to get blood flow down. Now, that's a more involved procedure. You're in the hospital a day or two, but the way things are done now, it's a lot easier than it used to be. But it still carries some potential risks. Risk of infection, risk of heart attack, anesthesia and stuff. Overall, your complication rate to surgical bypass is about 4% at most. But nevertheless, it's a more invasive way of handling things, but the data suggests that in situations where you have a good conduit, a good vein, that's probably maybe a better alternative for you if you're a fairly good risk patient, because it tends to work better. Now again, I'm not going to get into the nitty gritty of this stuff, but essentially the long and short of it is, whether you're doing endovascular technique or whether you're doing surgical bypass, you're rerouting the blood flow, getting it down to the foot so that the wound will have a chance to heal. And the endovascular techniques and the surgical bypass techniques, they're not foolproof by any means. You can have recurrent problems, you can have these bypasses blocked off, and therefore you need regular surveillance. It's critically important that you undergo regular surveillance in the office. And I'll kind of talk about that more when I talk about the non-invasive evaluations that you go through in offices, because I think it is important to understand what's the point of that. When we have residents, surgical residents, we teach this stuff to them so they understand when is it important to do this test and when is it important to do another test, when is it important to do both tests together so that you get a better idea of what the circulation looks like. But it's really critically important to follow up after a surgical bypass or an endovascular intervention to make sure that stuff stays open, because it's not a lifelong guarantee for this stuff. And so you want to be monitored lifetime for it. But in a nutshell, that's revascularization or getting blood flow down to the foot in situations where we have critical limb ischemia. Now, if you have intermittent claudication, that's that tightness in the calf muscle when you walk, and it's really affecting the quality of your life. You've tried conservative management. Your blood pressure, cholesterol is under excellent control. You're not smoking. You've tried plus or minus the medications that Platol, see if it helps you. Gone through an exercising program, whether it's supervised or at home. Generally speaking, supervised programs are better for you. Supervised programs where you go to a therapist and you really kind of works you out. And you still have a lot of discomfort and it's really affecting the quality of your life, then think about angiogram, endovascular techniques, or surgical bypasses for that situation. By the way, when you get that tightness in your calf muscle when you're walking, the claudication pain, there's no damage to the muscles. I see a lot of patients who come in with intermittent claudication, the tightness in their calf muscles. and they say, you know what, I stopped walking because I was worried that I was damaging the calf. Well, you're not damaging the muscles. It's the muscles saying, hey, we're not getting enough blood down here. Bring us some more blood. And so the tightness in the calf muscle when you walk is a stimulus to your body. Hey, we need some more blood down here, so the body kind of can respond and develop alternative channels to get more blood down to your calf muscle. But remember, this doesn't happen overnight. It takes a while for that improvement to really stick to the exercising program to see any benefit from it, okay? But anyway, if you have symptomatic claudication, it's refractory to maximal medical management, conservative management, and it's really affecting quality of your life, by all means, think about getting it fixed endovascularly surgically. So I think next time what we'll talk about is non-invasive testing, just so, no, that's not going to take very long. We'll just kind of briefly talk about non-invasive testing as compared to angiography and intervention and CT, and I'll kind of compare that to CT angiogram. So the gold standard really is angiography. That gives you the map of what everything looks like. CT angiograms are good, non-invasive other testings are good. So we'll talk about the non-invasive stuff later, and then kind of move on from there. We'll talk about other arterial problems of the lower extremities we need to discuss, including emergent kind of situations that occur. So we'll get into that more at a later date.